So now we're going to look at Chapter 14, Depressive Disorders, and I may go through this rather quickly, but I promise to slow down and emphasize important things that you need to know. So today we're discussing depressive disorders, one of the most common mental health conditions that nurses will see in their practice. Depression is more than just a feeling of sadness. It is a medical and psychiatric condition that affects your mood, thinking, physical health, and ability to function. Patients with depression often struggle with low energy, poor concentration, sleep problems, feelings of hopelessness, and as nurses, we must recognize these symptoms early because depression is strongly associated with suicide risk. So our objectives for this unit is by the end of this lecture, we want you to be able to identify symptoms of several depressive disorders and understand how common major depression is, and identify biological and psychological risk factors. The goal is to help you recognize depression in patients and understand treatment options. Depressive disorders share similar symptoms. Some common symptoms include sadness, feeling empty, irritability, physical complaints like fatigue and pain, and difficulty thinking clearly. Depression affects how people think, how they feel, and how they function. Patients may struggle with work, school, relationships, and self-care, and this is why depression is considered a serious mental illness, not just a temporary mood disorder. There's types of depressive disorders that we're going to talk about. Depression is not just one condition, it's several types. So some of these are listed as major depressive disorder, and this is the most common and most severe form. Disruptive mood dysregulation disorder, seen in children with severe irritability and anger. Persistent depressive disorder, or dysthymia, a chronic low-level depression that lasts years. Premenstrual dysphoric disorder, severe depression symptoms related to the menstrual cycle. Substance-induced depression, and this depression is caused by drugs, alcohol, and medications. And then depression from medical conditions, like certain illnesses can cause depressive symptoms. Disruptive mood dysregulation disorder, diagnosed in children ages 6 to 18. The symptoms are constant and severe irritability and anger, temper tantrums out of proportion to the situation at least 3 times per week, exhibits symptoms in at least 2 settings, home, school, and with peers. Treatment includes cognitive behavioral therapy and parent training, sometimes medication. Persistent depressive disorder, dysthymia, and I think I'm saying that right, is a long-term mild depression. Patients feel depressed most days for years. The diagnosis requires 2 years in adults, 1 year in children. Symptoms may include poor appetite, sleep problems, low energy, low self-esteem, difficulty concentrating, and hopelessness. Most of the time the patients are going to say something like, I've felt this way most of my life. Premenstrual dysphoric disorder occurs in women before menstruation. Symptoms appear in the week before the menstrual cycle and improve once the cycle begins. Common symptoms include mood swings, irritability, depression, anxiety, difficulty concentrating, and this condition is more severe than typical PMS. Other depressive disorders, substance-induced depressive disorder. This is where a person does not experience depressive symptoms in the absence of drug or alcohol use or withdrawal. The second one here is depressive disorder associated with another medical condition. Sometimes occurs with CVAs, Parkinson's, Alzheimer's, hypothyroid, arthritis, back pain, and the list goes on. You can read those there. Nurses must always assess medical causes of depressive symptoms. Depressive disorder. Major depression requires 5 or more symptoms within a 2-week period. These symptoms include appetite or weight changes, sleep disturbances, fatigue, feelings of worthlessness, poor concentration. They may have thoughts of death, psychomotor agitation, and at least one symptom must be depressed mood or loss of pleasure called anhedonia. Symptoms must last at least 2 weeks. Some episodes last months or even years. Some key features to discuss: causes significant distress, interferes with daily functioning, no history of mania, otherwise it may be bipolar disorder. Depression often recurs throughout life. Epidemiology, leading cause of disability in the United States. Children and adolescents and older adults are all affected. Elderly individuals as well. Another key point is comorbidity. Many patients experience both anxiety and depression at the same time. Risk factors. Several biological factors that increase risk are things like genetics. Depression often runs in families. Biochemical factors, changes in the brain, like neurotransmitters such as serotonin, norepinephrine, and dopamine. Stressful life events, things like divorce, job loss, or trauma in one's life. Some cognitive factors, cognitive theorists believe that people may acquire a psychological predisposition to depression due to early life experiences. These experiences contribute to negative, illogical, and irrational thought processes that may remain dormant until they are activated during times of stress. Just a few more additional risk factors include female gender, adverse childhood experiences, stressful life events, substance abuse, chronic illness. Medical problems such as diabetes, heart disease, or chronic pain also increase risk. The most important nursing process assessment is the assessment of suicide. Assessment areas begin to include behavior, if they may have low energy or anergia, mood, depressed mood and anhedonia, that's loss of pleasure. They may experience emotions like worthlessness, hopeless, feeling guilty, feeling helpless. And some of the thought pattern they may experience is delusions and hallucinations. The self-assessment, patients with depression may reject encouragement. They feel hopeless. They believe nothing's going to help them. We cannot fix depression quickly. Instead, we maintain realistic expectations and support the patient with consistency. Patients with depression often reject advice, encouragement, and understanding of others. They often seem unresponsive to nursing interventions and resistant to change. If your assignment is to have a therapeutic interaction and your patient will not talk to you, you may feel like a failure. When this occurs, the nurse may experience feelings of frustration, hopelessness, and annoyance within themselves. The question that would be a priority when assessing for a symptom of major depression, the answer is B. You look really sad. Have you ever thought of harming yourself? The reason that's the correct answer is because when assessing depression, suicide is always the priority, and safety. Safety is most important. Here are some nursing diagnoses that could be applied: risk for suicide, low self-esteem, poor nutrition, sleep disturbance, ineffective coping. But remember, safety is always first. Outcomes identifications recovery model. Modern mental health focuses on the recovery model, which means that focus is on the patient's strengths, collaborate with the patient, develop the goals together, and care should always respect the patient's values and their preferences. So the planning as part of the nursing process is geared toward patient's phase of depression, the particular symptoms, and the patient's personal goals. The implementation phase occurs in 3 different phases. So depression treatment occurs in the 3 phases, number 1 being the acute phase, which is the 6 to 12 weeks. And then there's the continuation phase, that's 4 to 9 months. And then the maintenance phase is 1 year or more. So in the acute phase, the focus is to stabilize the symptoms. In the continuation phase, it's to prevent relapse. And then in the maintenance phase is just to prevent further episodes. Nursing process continued. I'm going to talk a little bit about communication techniques. So communication with depressed patients must be simple and supportive, using concrete words, clear language, allow time for them to respond, listen very carefully, and ask directly about suicide. Avoid saying things like, well, just think positive, or others have it worse. These responses minimize the patient's experience, so we have to be very careful with our words. When a patient is silent, avoid direct questions and make observations to reinforce reality. Treatment modalities. When selecting antidepressants, providers consider their symptoms, their side effects, their past response to other medications, their medical conditions, and the ease of use. Continuing on with the pharmacotherapy, medication is one of the most important and common treatments for depression, and that choice depends on the patient's tolerance, medical history, their safety profile, and medical considerations. So now let's talk about our antidepressant classes, and you will need to be able to differentiate between these classes. So your SSRIs are the first line therapy. Rare risk of serotonin syndrome. Some examples of SSRIs are the sertraline, which is Zoloft, fluoxetine, which is Prozac, and the escitalopram is Lexapro. Then there's the SNRIs, and they may be tolerated a little better. They're a newer generation of antidepressants, but they have been around for a really long time. A couple of examples of those would be Cymbalta and Effexor, and they increase serotonin and norepinephrine. The tricyclic antidepressants, they have the anticholinergic adverse reaction. You want to know that. And then Mayo inhibitors are used for resistant depression, and they're effective for unconventional depression. Okay, so these new antidepressants, I have redone this slide like 3 times because I can't say these words, so I'm going to do the best I can. The new medications include the NDRIs, the SARIs, the NASSA medications, and then the 2 other new drugs, if you'll look on your screen, is esketamine. Also, I'm going to refer you to your book on page 257. It's got some good information about this medication used for treatment-resistant depression. And the brexanolone is on page 259, used for postpartum depression. There's also a chart on page 258 to 259 that I encourage you to look at. It's got a lot of good information, and I think you'll get a lot of good reading from that. Okay. Other treatments for depression, the integrative medicine is the St. John's wort sometimes is used. The brain stimulation therapies like the ECT, light therapy, vagus nerve stimulation, deep brain stimulation, and exercise, of course, is good for depression. So more about St. John's wort. It's a flower processed into a tea or tablet. It's thought to increase serotonin and dopamine in the brain. This herbal supplement may help mild depression. However, it does interact with a lot of other medications, so the nurse should always ask patients about herbal supplement use. And it's useful in mild to moderate depression. Okay, so let's dive into these therapies. The electroconvulsive therapy, or ECT, is the most effective depression treatment. Psychotic illnesses equals second most common indication. ECT is the primary treatment in severe malnutrition. exhaustion and dehydration due to the lengthy time of depression that a patient may be in, safer than meds with certain medical conditions. It's used for delusional depression, failure of previous medication trials, and schizophrenia with catatonia. So basically it's used when medication fails, somebody's got psychotic depression, severe malnutrition. Repetitive transcranial magnetic stimulation. It's a non-invasive treatment where magnetic pulses stimulate areas of the brain involved in the mood. It uses the MRI strength magnetic pulses to stimulate focal areas of the cerebral cortex. Presence of metal is the main contraindication, and adverse reactions include headache and lightheadedness. The vagus nerve stimulation, this therapy uses electrical stimulation of the vagus nerve. It increases neurotransmitters involved in mood regulation. It was originally used to treat epilepsy. So electrical stimulation boosts the level of the neurotransmitters, and some common side effects are voice changes and neck discomfort. Deep brain stimulation. Surgically implanted electrodes are placed in the brain. These stimulate underactive brain areas involved in depression. This treatment is used only for severe treatment-resistant depression. More invasive than the VNS because the electrodes are placed directly into the brain. So light therapy treats the seasonal affective disorder, otherwise known as SAD. This condition occurs when reduced sunlight affects melatonin and your circadian rhythm. So basically, patients just sit near a bright light box daily. So why does this happen? Reduced sunlight affects the brain chemicals that regulate mood. Sunlight normally helps regulate your serotonin and your melatonin and your circadian rhythm. So less sunlight, the serotonin decreases and melatonin increases, leading to depression and fatigue. So that's why it happens. Exercise improves depression through biological effects, psychological effects, and social interaction. Exercise increases the serotonin levels in the brain. If you are an avid exerciser, you know that you can testify to the fact that exercise makes you feel better, and if it's something that you routinely do on a week-to-week basis and for some reason you're unable to exercise, you feel it emotionally, physically, it makes a difference. So it's true that exercise does increase serotonin levels in the brain and makes you feel better. Our last slide, advanced practiced interventions. We're going to talk about psychological therapies. The cognitive behavioral therapy is the CBT. Interpersonal therapy, IPT, time-limited focused psychotherapy, and behavior therapy. Also, group therapy. These therapies help patients change negative thought patterns, improve coping skills, and build social support. We will talk about these topics more in class, and this is all we have for the slides today. Thank you.